Good evening, everyone. We welcome you all to OrthoTV in association with Spine Association of Gujarat. To introduce today's speaker, I hand over to Dr. Subir Zaveri.
Thank you, Niraj. As always, we are indebted to OrthoTV, Niraj, and your team for the entire last year's virtual so many seminars that you have taken us through. Let us quickly let me introduce the speakers. We have quite a full national faculty over here. We have Suryaprakash, who is scoliosis and spine surgeon from Hyderabad. Bhavuk, Bhavuk Garg is from AIMS. He is a very prolific and an academician as well. He has sort of set a records of sorts for publishing papers during the pandemic. And then we have Ranjith Unnikrishnan, who is again one of the masters from Kerala. And we are still missing Dr. Saumyajeet Basu from the eastern corner of India. Besides that, we have our two local faculties, Dr. Amit, Jhala, and there we have Basu joining in, Dr. Tarak, Patel, and Ajay Krishnan, all three from our Spine Association of Gujarat as well. So I hand over the mic to Niraj to start the proceedings.
And Dr. Suryaprakash from Hyderabad.
Welcome, Saumyajeet. Welcome to the first session of AIS, How the Masters Think, the brainchild of our secretary, Dr. Niraj Vasavada. Over to you, Niraj.
Thank you, Subir Bhai. And at the outset, I would want to welcome all the faculties and all the delegates who are watching this webinar. The idea of this entire program is to dissect through the Lenke's classification. Lenke's classification sometimes can be confusing, sometimes it leads to solutions, sometimes it confuses more. So we at SAG decided along with our president, Dr. G.D. Thadadra, to dissect it and demystify the classification of Lenke and learn from masters that how to treat. So the program goes, Dr. Tarak will introduce us with what is the Lenke's classification and what are the radiological nomenclature which is required to be learned to understand AIS. And then each faculty will take up one Lenke curve and demystify the curve, that how to manage, how to think, how to plan, how to avoid and how to execute things which you have planned. So without much ado, let me invite Dr. Tarak Patel to make us understand the curves and Lenke's classification. Tarak Patel.
Tarak, you are muted. We can't hear you.
Yeah. I think now I'm audible, right?
Yeah.
Okay. So let us start. So basically, as Niraj has mentioned, my job today is just to make the foundation. This is the very important basic lecture on learning how we classify Lenke's according to the Lenke's classification, the scoliosis AIS, and we also will learn some important radiological parameters which will be definitely utilized if you understand those, then only you will be able to understand what our masters will be speaking in their next lecture. So let us start and dig deeper. So basically, the Lenke's classification is a three-step classification. We all know that. It is definitely
sorry, Tarak, sorry to interrupt. You have also shared the full screen. You have to share only your presentation. There are two black bars which are coming in the middle.
Okay.
Just stop your screen share.
Yeah.
Or you can remove those bars also. That is also a good idea. And when you're sharing, just share your keynote. Do not share your full screen, not the first option. Look at your keynote option and then select that.
Okay. Just
double click on the keynote after clicking share screen.
Yeah, share screen and then
find your keynote.
Yeah, it's that keynote. I already
double click.
Keynote only. Yeah.
Yeah. Still it is coming.
Yeah, but I selected keynotes only.
Okay.
Okay. Is it okay now?
Yeah, the black bar is still coming. I don't know why.
No, it's not visible on my screen actually.
Okay.
Okay.
Go ahead.
So basically, it has definitely very good reproducibility and accurate and high intra and inter-observer reliability. There are 3 steps. The step one is we identify the different types. There are 6 types. In step 2, we assign the lumbar modifiers, and step 3, we assign the sagittal thoracic modifiers. So let's start understanding these all 3 steps one by one. Before we start classifying the AIS, there are few mandatory radiographs which are required to be utilized in Lenke's classification, and there are 3. One is standing AP or PA view, second is standing lateral, and third is supine right bendings and left bending X-rays. It has to be very nicely visible. The radiograph must be acceptable, and both the rib cages, the border of the rib cages, the C7, femoral head, there must be nicely visualized. Then only you will be able to classify it properly. So again, this is the lateral view, which is full length, and again we can see from C2 to sacrum, all vertebrae are almost visible. Many times you may not be able to see T2, which is very common because of the it's definitely a difficult area to visualize on lateral X-rays. This is not acceptable X-ray because the C7 is not visible down. If you look at the pelvis, it's not visible properly. So these are the X-rays which are not acceptable to be to be utilized in classifying the AIS as per the Lenke's classification. Again, here we can see the examples of the X-rays which are definitely not acceptable to be used. Lateral, again, a blurred image, half images or something which is not visible, the C2 not visible at the upper end. These are the X-rays which must be avoided. There are a few optional X-rays also which are used basically to identify the flexibility. So now let's start with the first steps. The first step is to identify the primary curve. There are 6 different types. The region of the curve is decided according to the SRS definition after locating the apex. So if the apex is between T2 to T12, 11-12 disc, then it's a thoracic curve, and likewise the other criteria utilized just to name the curve first. And then first step is to identify the structural curves and non-structural curve. So the first step is the major curve, which is the largest curve, is by default the first structural curve, irrespective of whether it is flexible or not. So it can be either main thoracic or thoracolumbar lumbar. If proximal thoracic curve is the largest curve, which is very rare, then in that cases we will have to consider the main thoracic curve as a major curve. In type 1, 2, and 3, MT will be the major curve, and type 5 and 6, thoracolumbar lumbar curve will be major. And in type 4, which is the triple major curve, where the larger curve is considered as a major structural curve, and if both are equal, then MT is considered as a major structural curve. The minor curve, then we will have to identify whether it is structural or non-structural, depending on the flexibility. So if on coronal side bending, if it bends less than 25, then definitely it is a non-structural curve. But if it does not bend to less than 25, then it is considered as a structural. Again, in the first category, even if it is a flexible and on bendings it becomes less than 25, but if in sagittal plane, if there is a kyphosis of more than 20 degrees, then again that has to be considered as a structural curve. So once you classify all these 3 curves as a whether it's a major curve or if it's a minor curve, then you classify whether it's a structural and non-structural. And from the combinations, we can get the 6 different types. And we all know that in the first type, the structural curve is there is only one curve which is structural, other 2 are non-structural, and that is main thoracic. In type 2, both thoracic curves are structural curves, but the major one is a main thoracic curve that's considered as a double thoracic type 2. Type 3 is again, there are 2 major curves. One is in the thoracic, main thoracic, and the thoracolumbar lumbar, and the proximal thoracic is non-structural. So it is called a double major or type 3. Type 4 is a triple major where all 3 are structural. Type 5 is again, it's only located in the lower half, that is the lumbar and thoracolumbar, where the main thoracic and proximal thoracic curves are non-structural. And type 6 is again like similar to type 3, but the only difference is in this type, the thoracolumbar lumbar curve is the major curve as compared to the main thoracic curve. So this is the first step. And I think, Okay, so let's see an example. This is the case where we can see on the standing X-ray there is around 51 degree corpse, and when we see the bending X-rays, we can see that it is bending to more than 33. Even if it's flexible or even if it bends less than 25 degree, it has to be considered because that's the single largest curve. So the major curve here, so this type will be a type 1 curve where there is only a main thoracic curve is structural and there are other two curves are non-structural. Similarly, in this case, we can see that the major curve is the thoracic curve, which is 65 degrees. So that has to be considered as structural. The other two are more than 25, but when we see on bending, it is definitely correcting to less than 25. So we may thought that this is only a primary or main thoracic or type 1, but the catch is in the lateral X-rays where we can see that there is a thoracolumbar kyphosis, which is 26 degree. So this has to be considered, the lumbar curve should be considered as a structural curve because of the second criteria. So this will be classified as a type 3. In this example, we can see that there are 3 curves, all are more than 25 degree, and the major curve is 87 degree of the main thoracic, while the other 2 are not bending to less than 25 degrees. So all 3 curves are structural curves, and this is considered as a triple major or type 4, Lenke type 4. The second step is to assign the lumbar modifiers. So the lumbar modifiers, there are 3 modifiers, A, B, and C. And it is the referral line which we use here is CSVL, central sacral vertical line. So if this CSVL is passing in the lumbar curve, if the apical vertebra, if it passes between the 2 pedicle, then it is considered as a type A. If CSVL touches the lateral part of the pedicle or medial, if it passes between the medial part of the concave pedicle or the lateral edge of the horizontal or the apex vertebra, then it is considered as a type B. And if the CSVL is not passing through the apex, if it is lateral to the apical vertebrae are lateral to the CSVL, then it is considered as a type C. If it is difficult to decide between type A or B or C, then in those cases we have to assign this as a type B modifier. And when the apex is at disc, the lumbar modifier is determined by the position of CSVL in relation to the vertebra, which is above and the below. It is very important to identify the apex first, and basically the apex is the most horizontal vertebra, and in some cases it may be the most laterally deviated vertebra. So basically in modifier type A, where it is not deviated, it is the most horizontally placed vertebra or the disc is the apex, while in the type B modifier or type C modifier, it is the most horizontal as well as the most laterally deviated vertebra. So here we can see its type. On the top of the chart, we can see there are different type of first step, basically type 1, 2, 3, and 4. And if you see at the bottom of the curve, all CSVL is passing between the pedicle of the apex of the lumbar curve. So these are A. Here, these all are the example of the lumbar modifier B. And this basically type 1 and type 1, 2, 3, 4, 5, 6. All types can have the lumbar C modifiers. The third part or the third step is to assignment of the sagittal thoracic modifier, which can be of 3 types, minus, N, and plus. Here, the kyphosis is measured between D5 to D12. And if it is less than 10 plus 10 degree, that is if there is a up to 10 degree of the lordosis, then it is considered as a hypo. From 10 degree lordotic to 40 degree kyphotic, it is considered as normal. And if it is more than 40 degree kyphosis, then it is considered as a plus. And this is how we can get all these different combinations of 14 curve types, as well as then we can have these 3 different sagittal parameters. So we can have in combinations total 42 different classifications according to Lenke's classification. Here again, the same example which we have seen. Now we can see here the CSVL is passing between the apex, so the modifier is A, and just hold on. Yeah, and in the lateral view we can see that the kyphosis is 32 degrees, so it is N. So this is the classified as type 1 AN. The second example which we saw, which was curve type 3 because not because there is a thoracic curve is measured, but lumbar curve is considered as a structural because DL kyphosis is more than 20 degree. So in this case, the lumbar modifier is C because we can see that apex is at L2, which is definitely laterally deviated. And sagittal modifier, the kyphosis is 24 degrees. So it is again considered as a type 3 CN. And similarly, we have seen this third example, which is type 4. Again, C modifier and sagittal, we can see that the kyphosis is 45 degrees. So it is plus. So this is considered as a type 4C plus. So basically, this is how we classify AIS according to Lenke's classification in 3 different steps. Now, I'll quickly go through different radiological parameters which will be utilized by our esteemed faculties. Because what happens is Lenke's classification give you a broad guideline where to stop and what levels to be included into arthrodesis. But many a times there are some gray areas, and those gray areas require some fine tuning, and those are the different radiological parameters which will be utilized, which are utilized basically to fine tune the decision making whether where to stop to decide the UIV as well as the LIV. So first is end vertebra. End vertebra is the most tilted vertebra at the cephalic and caudate end of the curve. Basically, end of the curve, the most tilted vertebra is considered as the end vertebra. Neutral vertebra. So we all know that at the apex, the vertebra is maximally rotated, and as you go down and you try to go out of the curve, the vertebra is basically derotated to the normalcy. So the first cephalad vertebra, so most cephalic vertebra which becomes normally rotated, that's considered as a neutral vertebra. And stable vertebra is again beyond the curve. So beyond the curve, the uppermost vertebra, which is most closely bisected by CSVL, is considered as a stable vertebra. The Rhesus sign is utilized basically to find out the probability or the rate of the curve progression. So if it's rises 0 where there is no iliac apophysis, we can consider there is lots of growth potential is left. And if it is riser 5 where there is a complete ossification of apophysis with fusion to ilium, then the growth potential is definitely not that much. Similarly, triradiate cartilage, if it is open, still there is some growth left, and if it is closed, then we can consider it is that patient is going towards the maturity. These are the Nash-Moyes classification or the grading of the rotation of the vertebra, which can be many times utilized in deciding if you want to just do selective thoracic fusion and then confused whether where the L1 and L2, many times there is some confusion where to stop. So in those cases, you use this rotation grading to decide. The another important parameter is apical vertebral translation, and basically the apical vertebral translation is measured in a reference to of the two line, the C7 plumb line and CSVL. If these both lines are in synchronization, then you can take the apical vertebral distance from this line, or if both are not in the same line, that is because of the coronal imbalance, then the lumbar curve apex is measured from CSVL, and in main thoracic, the apex deviation is measured from C7 plumb line. Coronal balance, again, we can see that this is a method. From the lateral edge of the radiograph, we measure how far is the C7 plumb line and how far is the CSVL, and the difference is considered as a coronal imbalance. T1 tilt is very important because many times post-op there are shoulder imbalance, so intraoperative also you need to look at the T1 angle. Also, in many cases of the proximal thoracic curves, T1 tilt is helps us in guiding the upper instrumented vertebrae. Truncal shift, and the last but not the least is the sacral obliquity, because it is very important, particularly if it is the oblique setup of L5. Many times it can give you a patient may go off balance even after doing the surgery. So there are three kind of sacral obliquities you can get. One is sacral obliquity without any LLD. The type 2 is where there is a limb length discrepancy along with sacral obliquity, and in type 3 is only there is LLD without any sacral obliquity. So this is also very important, basically, particularly when you are going till L5. So these factors are definitely important to be considered. And this is the book which is very nice, and I have used as a reference along with the AIS adult deformities as well as listhesis parameters are very nicely described. So those juniors who want to just learn more about the radiological measurements in all kind of spine deformity, this is definitely a great book to have. So thank you very much. Thanks, Niraj, for the opportunity.
Thank you, Tarak. Thank you so much. May I request all the faculties, because this is probably a kind of a teaching course, so every faculty is highly experienced about things. So please feel free to put any inputs you have from your experience about any of the talks, because everybody handles all type of curves. So I have probably requested each faculty to take one curve, but please, involve into other curves also with your experience. Any tips you would want to give. So I guess, I will quickly go to the first lecture. May I invite Dr. Bhavuk, and please let us take through your thought process of managing Lenke type 1 curves. Over to Bhavuk.
Thank you, Niraj. So is my slides visible now?
Yes.
Yeah. So thank you, Spine Society of Gujarat and Niraj for giving me this opportunity. So as rightly said by Tarak, the most important step is to reaching a correct diagnosis when we follow the Lenke's classification. Tarak has already covered it, and it is important to recognize that the sagittal profile is also very, very important when we look at these Lenke curves. This is a standard Lenke 1 curve. You can see on bending films, only the thoracic curve remains. So this is the classical Lenke 1 curve. Now, if you look at these curves, they all are Lenke 1. The reason is that the apex of the Lenke 1 varies from T2 to T11, T12 disc, and usually it is below the T6. So actually, this is the most the comprehensive and the largest group among all the Lenke types, because its apex varies very widely. And one should not forget the rotation, because if you look at the 50-degree curves, Lenke 1, they all may differ in their rotations as well. The rotational component is missing from the Lenke, so which forms an important part, because you keep on following your patients, and if you measure the rotations at different intervals, so the rotation may keep on increasing, but the corpse angles, that remains the same. So the decision making to operate or not, it depends upon the corpse angle nowadays. So if the curve is more than 50 degrees, there is a greater risk of progression. We operate, we all know this, and if it is less than 40, we observe. Between 40 to 50, it remains a gray zone, which depends upon the various things. I'm not going to details. The goals of treatment, we all know that we want to prevent the progression of the deformity. We want to achieve the alignment with as short as fusion as possible. And we have to identify some high risk curves and recognize the subtle progression as well. And always, if I'm operating in my practice, I always get a MRI done, and we rule out the other systematic abnormalities. So when you are assessing a Lenke curves, you have to look around every corner. And like in this curve, one has to very importantly recognize that sometimes, especially in large curves, these ribs, they may impinge upon the pelvis. So they may not give you the correct estimate of the bending correction. So it may limit the correction. So one has to be very, very careful this thing. So this is like a sort of Lenke 1 curve. And when we looked at the sagittal profile, you can see that there is a very severe thoracolumbar kyphosis as well. So, and these can be, very much mistaken in larger curves. So one has to be very careful. And this Lenke 1 was actually Lenke 3. So coming to once you have planned to be operated these patients, then you have to determine your proximal fusion level. Then you have to consider the preoperative shoulder balance, and you have to also consider that when you are going to correct your thoracic curve, how much it is going to affect the shoulder balance. And you can look at the various parameters like the radiographic shoulder height, T1 tilt, coracoid height, first strip clavicle height, clavicle angle. Many angles have been described, but the best radiographic predictor angle remains the clavicle angle as per the literature. So the usual dictum is that if it is a right thoracic curve and the right shoulder is high, you go up to T4 or T5. If it is there are the both shoulders that are the same level, you go up to T3. And if the left shoulder is high, you go to the T2. And this is a very good article from the Herborde, who has considered the T1 tilt and the shoulder balance as well. And then they have given these alpha and beta angles, and on that basis they have described. So there are, when there are so many things described, you can understand that there are so much controversies is going on, and nobody has got the perfect answer. So especially when you have got the larger curves, and if there is a right shoulder elevation, in my practice I have seen that even the T3 is tilted into the curve. That means the T3 becomes the end vertebra. So obviously you have to go to T3. So you have to consider the various things as well. Now this is a classical case, in which looks like a Lenke 1. And when correction, we saw that we have missed the proximal thoracic curve. It was not on all measurements, angle measurement, it was not structural curve, but you can see that post-operative X-ray, probably we have missed this kyphosis at the T2, T5 level. So this is again a mistake from our part. So recognizing a proximal thoracic curves becomes very important. Like in this curve, you can also miss the proximal thoracic curve. But again, we could identify the proximal thoracic curve, and we went above, and the shoulders, they remained balanced in post-op. Distal fusion levels, various criteria have been described, including ranging from end vertebra, stable vertebra, neutral vertebra, substantially touched vertebra, the neutrals, and as well as the substantially touched vertebra, and the sagittally stable vertebra. There are no established guidelines, and there are various variations among the various authors. And we have to also understand that conventionally we used to go from stable to stable, which was in the Harrington era. But now we have a 3D correction with the help of the pedicle screws. So again, the relationship between these all sort of, the guidelines, that depends upon the flexibility of the lumbar curves. The disc is neutralizing or wedging on bending films, derotation. We will also discuss about the L4 tilt and the thoracolumbar kyphosis. So this is the classical SUK guidelines, which says that if the neutral vertebra is end vertebra, or the neutral vertebra is one level distal to the end vertebra, then you go to the neutral vertebra. And when neutral vertebra is more than 2 level distal to the end vertebra, then you can fuse to the neutral vertebra -1. These are the Lenke's guidelines, that if there is a lumbar curve with 1A, L, 1B, and 1C, then you fuse to stable vertebra. And if there is a Lenke 1 curve without a 2 lumbar curve, which is the 1AR, then you go to the last substantially touched vertebra. So there is another classification which says that if the pelvis is included, that means the pelvis is tilted in the other direction, that it goes up to, you have to go up to at least L4. And if the pelvis is excluded, then the fusion can end at L1. And we published this actually article last year, that we looked at the Lenke and the PUMC classification, and there was no statistically significant difference whether you follow a particular recommendation of a guideline as well. So this is very important to recognize the 1AR and 1AL curves, especially when we talk about the Lenke 1. It depends upon the L4 whether it's tilted towards the left side or if it is tilted towards the left side. So distal adding is more common if you fuse short in 1AR. So this is very important to recognize. So distal adding on phenomena is basically, when the distal curve worsens after the post-op period. So it depends upon the choice of the distal fusion levels. If the LIV minus last substantial touch vertebra is not the same, if the immediate post-operative apical vertebral translation is more than 25 mm, and we follow the Mianji's classification, that is the 1AR and the 1AL1. So like this is an example, this is a 1AR curve. The L4 is tilted towards the right only, and the last touch vertebra is L2, and the stable vertebra is L3. So in this, we went up to the L2, and we can see that there is a distal adding on in the post-op period. So this is another example, which is Lenke 1AR again. Now it is important to recognize that it is a left-sided curve. So here we have to consider the L4 tilt on the opposite side. So in this, we chose the stable vertebra, and we got a good correction in this thing. So coming to the selective thoracic fusion, again, we all know that we want to fuse as short as possible. It also depends upon the spontaneous lumbar curve correction, which is usually around 50 to 70 degrees of the curve. So it is also important to recognize that you don't have to correct the thoracic curve over-corrected, because the spontaneous lumbar curve correction will not happen beyond 70 degree at the maximum. So correction is more than the flexibility of the curve. It is very, very important. Residual LIV, you can leave it a little bit tilt in 10 to 20 degrees if the lumbar curve doesn't correct less than 10 degrees on side bending. And avoid selective thoracic fusion in large stiff lumbar curves, even if your criteria are met. So curves more than 40 degrees, rotation more than 2, Nash and more grade 2, and flexibility less than 70 degrees, avoid selective thoracic fusion in these. There are various criteria in the literature. These are the Steve Richards criteria, Kamal Ibrahim's criteria. These are the Lenke's criteria, various clinical and the radiological parameters are there. You can all use them in your practice, but none of them matches to the perfect this thing. So apical vertebral translation is again has been cited as the most important of this criteria. So if the apical vertebral translation is more than 1.2, you can always go for selective thoracic fusion. But look at this case, this is our case. In this, the apical vertebral translation is less than 1.2, and we can get away with the selective thoracic fusions. So one of the very important criteria is to recognize that the reserve staging or the growth potential of the child, it also matters a lot. And how much tilt you leave in the LIV, it also matters a lot, that how much it can correct the lumbar curve. Coming to the correction techniques, I always use only the posterior column osteotomies. I have stopped using the larger osteotomies in AIS. I also add in very stiff curves. I also add the concave ribs release, which gives me a greater thing. But I have stopped using the VCR or the PSOs in AIS because it depends upon the deformity angular ratio as well. It is not rewarding when you do VCR or the PSO in an AIS. It is more rewarding in congenital one where there is a sharp kyphosis or sharp deformity, but not in AIS. Rods, I prefer the cobalt chrome rods and titanium if there is a poor implant fixation or osteopenia. I always use uniaxial screws in most of my construct. However, at the top in the neutral vertebra, I use the polyaxial screws. I always try to keep an implant density of around 75%. Between 1.4 to 1.8, it should be there. I use all sort of maneuvers which are there. My main mode of correction is the sequential multi-axial translation by Ktm system in AIS. However, I use everything, including the in situ benders and everything I use. I direct vertebral derotation, everything I use. So our strategy is to determine whether we are going to for selective versus non-selective fusion. Then we determine our UIV. We also determine our LIV. We target the implant density of around 65 to 75%. I use pedicle screws throughout. On my concave side, topmost, I use a pedicular hook. On the convex side, at the topmost, I use always a transverse process hook. I do grade 1 osteotomies at all levels and a grade 2 osteotomies at the periapical levels. Cobalt chrome rod. Concave rod is applied first if it is a thoracic kyphosis is low or normal. If thoracic kyphosis is high, I always go for convex rod first. Deformity, I have already told you my screws preference. Just a short video you can see here. This is how we do it under the hypotensive anesthesia, the exposure part. But when we do the correction, we go for the mean axial pressure is always kept at the more than 80 millimeter of mercury. So this is we are placing hook at the top. On the right of is the top part, and on the left is this thing. So this is a Ktm system rod bending. I think you are all aware. You can see that how I just keep my rod in the same position with the help of a wrench, and then the whole of the spine is translated towards the rod. And then we do fine correction with the help of the compression distraction, and finally we use these in situ benders to get the full correction. You can see the correction in top as well. And I always use a transverse connector below my hooks. And this is how we close the wound with the help of these special devices. And the one extra technique which we use when we go for selective thoracic fusion is, and this has helped us a lot, we use the Jamshidi needle in the vertebra distal, which is rotated, and then we derotate the distal spine in the other direction with the help of this Jamshidi, and then we finally lock our spine in that particular position. This is, you can see here that how we are rotating it in the different direction as compared to the proximal spine. So coming to anterior surgery is very useful in Lenke 1 because it is kyphogenic, but there are significant decline in pulmonary function, so we have stopped doing it, and we can just I don't do anterior release anymore now, and most of the correction we can get with the posterior release also. Traction again, I don't use traction for AIS cases. I use it for the deformity, the congenital cases, and in the neurofibromatosis and syndromic cases, but not for AIS. Now, just giving you an example, this is a curve, you can see here that this is a Lenke 1 curve, if you see, but her neck is also rotated into the other direction. So if you look at these x-rays, this will fit as per definition, this will come into the Lenke 1, but this is not a typical Lenke 1. So I don't know that how will you put it in which classification, but this is by definition, this is the Lenke 1, and COPS is 105 and T1 tilt is 80 degrees. So I have to go to the cervical spine, and there was no way I could put the pedicular screws because it was so much rotated, the neck was rotated. So I had to use a laminar screws along with the lateral mass screw, and when I derotated the spine with the help of this laminar screws, and this was and you can see that I have done a good concave tether release on with the concave rib osteotomies. I had to put the chest tubes in post-op, and I did this is the correction which you can see with these simple maneuvers we can get in AIS. Thoracoplasty is again a very good tool, especially in very stiff curves. The patients, they are worried about their cosmetic concern. They are not worried about. So if your head is balanced over the pelvis and You give them cosmetic good cosmesis, so this is improved. You can resect up to 6 ribs, but I usually never go beyond 3 ribs in my practice. So again, this is the type of curve you can see, seemingly looks pretty normal curve, and this is the child when came to us, we advised surgery, but then she came later, and now you can see that the corpse has become 127 degrees. So in these cases, these ribs, they they overhang above the entry points, so one has to be very careful. But when I looked at this thing, there was something abnormal, which I was very particular about this kyphosis here. And then we looked at the CT scan carefully, and you can see the CT scan that there was just at one level, the vertebrae, they are rotated into the different directions at 90-degree opposite to each other. So there was a 180-degree turn, just at the at a one this thing. So you can see here that the D4 is rotated towards the left and the D6 is rotated towards the right completely. So again, it was a very difficult case, and there was no category in Lenke and Kings in this category. But anyway, as per definition, this will come into the Lenke 1. So we used a special strategy. So we linked on these vertebrae which were rotated in the similar direction into the same rods, and then we derotated them into the different directions. And this is the immediate post-op X-rays, and this is the correction. With the help of the thoracoplasty, we could achieve a good clinical and as well as the functional result. EOS has changed because has changed our understanding of Lenke curves now, because we are looking at three-dimensional deformity from a 2D perspective. So this is the 3D picture which the EOS gives us, and now the people are also understanding these sagittal classifications which are coming up in AIS from Lenke group itself. The most important thing is this diagram which this EOS gives us, a 3D from the top views, and we can look at the rotation of the different vertebrae in this thing, and these are the vertebral vectors. I'm not going to details, but this is how you plan. You look at each and individual vertebra as per your bilateral femoral heads, and this is the Da Vinci view which gives your idea about the corrections. And you can look at that there are different clusters among these Lenke subtypes also. So we are coming up with a new 3D classification. This is from the SRS group only, and again, so this is a simple case of again a Lenke 1 C curve, and you can look at this thing. So we planned selective thoracic fusion, and we were planning to stop at the L1, which was the last substantially touched vertebra. But when we looked at the EOS imaging, we could see that actually the L1 is the most rotated vertebra. So again, we had to change our plan and we had to go down. So this changed our position. So this is very, very important to understand that the 3D understanding is very, very important. Thank you.
Thank you, Bhavuk, for an excellent overview and exhaustive understanding about Lenke type 1. Any quick comments from any faculty? Any questions? Subir bhai, you are mute.
Just elaborate on the Jamshidi thing, what you do with the rotation part. Just a quick answer.
So normally, we usually go for the last substantially touched vertebra. Last substantially touched vertebra in most of the cases is one vertebra distal to the neutral vertebra. So that means that the last substantially touched vertebra has a slight rotation towards the opposite side. So we add one more, we go into we put a Jamshidi needle one level distal to the last fused vertebra, and we derotate in the opposite direction. So this gives a, the correction effect on the overall the lumbar spine, derotates.
So it helps your rotation,
but we are not using that
and you don't fuse it.
We don't fuse it. So we just by minimally invasive way, we put it in that.
Okay. Thank you.
Bhavuk, the same thing cannot be done with the help of the last screw. You can put and rotate the last screw. Have you measured what is the difference between these two? Because to put an extra needle, you can do the same maneuver with the help of last screw where you can derotate it.
Sir, when you derotate, actually, that's actually the whole thing. Because when you are going one level distal, then you are translating a more derotation effect on the last vertebra, last fused vertebra. So this technique has been described by Suken. But this is not my technique. So this is they have shown actually. I'm not aware whether they have compared it or not, but we have found it very useful. And if you see the images of this thing, you can see that in post-operative and in pre-operative on the X-ray itself, when we have fused it, there is a significant correction in the derotation of that particular segment.
About one question from myself. You said that you don't do anterior release at all. So in a very high degree stiff curves, even though from posterior approach, do you do intradiscal release or you don't do at all, and not even intradiscal release for all these curves?
It's not required in my practice. We do thorough release, and when you cut these concave ribs, actually, then it gives a significant release.
Okay. So if there are no any more questions, thank you, Bhavuk. Thank you so much. May I invite Dr. Saumyajeet Basu to take us through his thought process about Lenke Type 2 curves. Basu, sir, your screen is not properly visible.
Is it visible now?
Sir, there is a big black block on your presentation.
And stop share again.
Yeah, I think, sir, you will have to only share your presentation as Niraj is saying.
Is it okay?
No, sir, there is still a black block coming in.
It's not visible on my screen, so I'll stop share and then see whether.
Let me just call Niraj.
Is it okay now?
Yes, sir. Now it is okay. Okay.
Right. So thanks, Niraj, for inviting me to this beautiful Saturday evening. And as opposed to Bhavuk, I'm not going to give a sort of big talk and really go through the ins and outs of all the classification. They have always been the bugbear of any AIS discussion. And I'm sure Tarak and Bhavuk has given us a great insight into the tits and bits of the classification. As you said, that I'm just going to walk through a particular case of mine, which actually should give us an insight into type 2. And as everybody knows, that type 2 is not very common. And there are two types of curves in type 2. One in which it is actually hidden amongst the huge number of type 1 curves we see. As you know, about 60 to 70% curves are type 1 in some way or the other. And there are hidden things in type 1. That means you have to carefully look at the shoulder height. And if you really find that the left shoulder is high, look for a proximal thoracic curve. And that is where the type 2 lies hidden. And in some type 2 curves, they're completely bare out. That means it's very easily seen that there is a big trapezoidal hump. As you can see in this particular girl, she is about 12 years, and the deformity was noticed by her parents about 5 months back. She's 1 year post-menarche with 2 siblings who are healthy, and the perinatal history is not significant. As you can see that the left shoulder is high, and over and above the left shoulder, what is important is to see this trapezoidal hump. And this gives the suspicion that there is a very highly rotated proximal thoracic curve, which needs to be really understood. The right scapula is higher, and if you see this trapezial hump actually drives the left arm trunk distance at a higher level and more than the right arm trunk distance. And there is obviously this right rib hump and the right scapular prominence, which everybody knows is due to the main thoracic curve, which is typically on the right side. So a right-sided main thoracic curve with a left-sidal trapezoidal hump with the left shoulder up in a young girl means that what you're looking at is a type 2 Lenke. And the pelvis is usually symmetrical because there is no lumbar curvature in these patients. Once again, before going further, I need to stress upon proper x-rays. They should be done with whole spine standing x-rays, AP and laterally along with the right and left supine bending views, AP. Additional views like traction films and bolster films are a routine in our unit, but these are the basic things which needs to be done. And whole spine standing x-rays should not be in one single shot. They should be usually in 2 or 3 shots and stitched by the computer according to the height of the patient. So in this patient, you see there is more than a 60 degrees curve in the thoracic, main thoracic, and a more than a 60-degree curve in the proximal thoracic. Now, what I will ask you to look into very carefully is the bending correction. Our radiographers are doing this routinely, so they really stretch the bending films a lot. And so this bending film gives you from 64, it comes down to 36, whereas that 62 comes down only to 50 degrees. And this is extremely important. Now, there are two important sort of fallacies, I would say, I might dare to say, in the bending films. Because in the proximal bending film, in my experience, does not, the proximal thoracic curve, in my experience, does not bend well. And as you can never put a bolster on that part, because the shoulder and the armpit comes in your view, you can really never assess the flexibility of these curves as you would really like it to be assessed. In this patient, the bolster film, as you can see, gives rise to, brings the curve, the main thoracic curve down to 30. And in the traction film, it comes down to 34.8. So if I go back to the previous slide, you see this curve is really, really very malignant, very highly rotated, and hardly comes back. So immediately I know, first of all, it is a type 2 curve. Secondly, you have to look at the sagittal profile a little bit more carefully. So this is T5 to T12, as in Lenke's classification, it's a 23 degree, which means it's a normal thoracic. And if you look at the T2 part of it, if you see here, the proximal thoracic goes up to T1. And that means that it is way deep down into the neck and the thoracic junction. And that is where your rod bending gives you an extremely important point of consideration during surgery. This is a technical point I always stress when I'm demonstrating this case to my juniors, that the proximal rod needs to be really bent into the screw. You can never try to pull the screw out into the rod. This is guaranteed to leave an ugly prominence, and this is guaranteed to fail usually in the first 3 to 6 months, and you can see that the proximal screw is pulled out. So maintain this curve. If you have to accept, if you have to bite the bullet early, if you cannot bring it down to less than 40 or 30, accept it. But see to it that your rod goes straight down to the screw rather than your screw coming up to the rod. So if this is a traction film, as you can see, this comes on 34, but again, this doesn't bend well. And in my practice for the last 3-4 years, I have been always taking a left-hand AP picture for understanding the curve progression. So over the years, we have learned that the riser grading actually does not give rise to a correct curve prediction, because by the time the triradiate cartilage is closed and by the time your riser 0 is over, that means by the time it is 1 or 2, your peak height velocity, PHV, has already been reached. And so Sanders classification, in which you have the 3 joints, that means the distal epiphysis into the distalmost joint, and then the proximal epiphysis into the middle joint, and then finally you come down below to the MCPJ. And in Sanders 7 and 8, which is the maximum maturity, that means it is riser 5, you will find that the wrist also has ossified completely. That means the distal radial epiphysis and the distal ulnar epiphysis is closed completely. So if you look at this table, it is in 1-2, it is juvenile slow or pre-adolescent slow. In this, you basically look at whether the distal epiphyses are capped or uncapped. And then comes the Sanders 3 and 4, which is a rapid adolescent growth, in which you look at this particular area to see whether they are capped or uncapped. And finally, in type 5-6, which is the steady adolescent growth, you look at the MCPJs, whether they're capped or not. And as I told you, 7 and 8 means its maturity stage. That means the wrist epiphyses are also gone. So this was a patient with a normal MRI, and that is how we planned out the incision. I'm not sure whether the video will play or not, but I shall try. Before that, let's go into the post-operative. This is what she got post-operative. This is a very recent case of mine. This is about 3 weeks follow-up only. And as you can see that the curve corrected to 26 and 29 with a good sagittal balance. I'll show you the sagittal balance a little bit later once we play the video. So this is what the sagittal balance looks like. It's about 22 degrees. And you can see that the curve is definitely better than what it was, but there is still a left trapezoidal hump which persists. Now, if you have to really correct this and if you have to derotate this part, there's a very high chance of proximal screw pullout, and that is what I tried to avoid. And this is the sagittal profile which we got. This is the AP preoperative and postoperative. And let's see if we can play the video or not. Can you see the video, Niraj?
Not yet, sir. Sir, while screen sharing, you will have to select that video player. So you will have to probably stop screen and select reshare it again.
I'll just see whether I can do this or not.
So when you reshare, sir, just select that video part, not the share your screen window.
I will select the video part.
Yes, sir. So,
Is it coming
yes,
in?
yes, the screen is there. Yes, coming.
So we do a neural monitoring for all these patients, and this is the first step in which the incision is marked out, and then after the exposure is done, the next step is to take a level marking. So before we go into that, so at this step, once the exposure is done, we take a level marking C-arm shoot, and that is the first C-arm shoot, and the next C-arm shoot is done usually after putting in all the screws. So this is how it is. That's the exposure going on. And then after identifying the level, then this is the first proximal screw, which is T2, which is going in. I'm using a drill bit for the initial entry point. And if you look at it very closely, so this is the fascectomy which is done. The fascectomy is never done at this level because this is the proximal level. And once we put in the awl, we usually do I probe it with my ball probe, and then I put in a cannulated tap. I put in the guide wire of the cannulated tap into the felt part of the probe, and then I put the screw in. So once the screw goes in, I will just show you how I do my fascectomy in the next minute or so. So this is the proximal screw going in, and followed by a fascectomy. This usually is done one by one, and all the serial fascectomies are done, and then I put in the other screws. And this is on the, once I put in all the concave screws, as you can see, this is the concave side, this is the convex side, this is the left side of the patient. I'm standing. I've gone over to the other side, that is the right side of the patient now. And this is the technique which I do. As you can see, I put in the guide wire over the hole, and that is how I'm doing a tapping over the guide wire. These are all the convex screws on the major thoracic curve. This is the expedium verse system which I am using. And once this is done, I would put in the screw. All these screws are put in freehand. I usually do not use the C-arm at this stage unless I have got stuck at one particular highly rotated vertebra. Once the screws are put in and I've checked by C-arm, I'll show you just how I check it with the C-arm. So that is the C-arm picture which now comes in. All the screws looks good, and then I take a measurement. This is the measuring device. The good old Bowie wire is a better one, but the implant company wanted me to test this out. Didn't like it that much. And then comes the rod bending, which is very important. The differential rod bending is something which I usually try to do, not much in this curve, but this is how I've learned to bend the curve. Initially, we were putting in the bench press bender, now I have shifted over to this. This is I learned from voyage, and the stress risers are much less. CC as well as cobalt chrome, they're very notch sensitive, and the more you use this technique, there are no notches in between. And once this gets bent properly, the final touches are then given by the bender. This is the final touches, a little bit of lordosis on the lumbar part, lower thoracic, which is straight, and the upper thoracic is much more bent than the mid thoracic. Now, on the concavity, especially on the left side, it's very important that you give a little bit more bend to the proximal part of it so that your rod goes into the proximal screws rather than sticking out. Now, this is the concave rod being put in, that is the left-sided rod. And there are markers in which there are reducers in which you can put this in. Now, all the Indian companies also have some reducers, and so this is how it is put in serially. I start from the lower downwards because the pull-out strength of the lower one is much more than the upper one. And these are the reducers which you can use for gradually reducing them. And ultimately, there goes the rod, and this is now ready for bending. So this is the first bend, as a first rotation which I do. If you look at it very carefully, the proximal two screws are still not captured. I mean, the rod is not captured into the proximal two screws. And 2 or 3 needs to be completely tightened before I let loose the rod holders so that I can go in for the next rod rotation again, which is a repetition of the same. So you see, this is 2 or 3 are tightened completely, and then it is released, and second rod rotation is done. This is the first one done, and now I'm opening it out. This is the second one going to come in, and all 3 of them go together. This is loosened out. While loosened out, there's a recoil which should be held by the assistant so that it doesn't recoil back. And then the next rotation goes in. And this is, now you can see that the proximal rod is going to be captured. And for this, a generous in situ bending has to be necessary so that the proximal rod goes into the screws rather than, as I told you, the screws coming out. So this bend actually brings the rod, proximal part of the rod, into the T2 screw, and so that there is minimal fiddling about with this procedure and no stress is given on the T2 and T3 screws. The next part is putting in the convex rod, and once the convex rod is also put in, again the care should be taken that in the proximal part, do not try to sort of be very heroic in your corrections, except that that is a very, very rigid curve. It's very difficult to do a very major correction into this. And that's how it is. After the proximal screws are captured. Now, once all the screws are captured, now you have to do the in situ rod bending. This is important to build up the sagittal profile and the sagittal kyphosis so that the sagittal profile is well built up and a normal thoracic kyphosis is well maintained. Now, the next step is segmental distraction and compression. This is the concave part of the proximal thoracic curve, which I am distracting from the apex. And similarly, as I've got a very good correction in the major thoracic curve, I'm not going to do any distraction compression there, but I'm trying to do whatever is possible on the proximal thoracic curve. And that is the concave distraction. As you can understand, this is the right side of the patient. And this is the convex compression on the proximal thoracic curves. The T2 gets as far as possible horizontalized. It's difficult, and be very, very careful in this part because these T1, T2, T3 screws are not very great screws. They are usually 30 mm, 5 mm screws. In very small cases, they might be 4.5. So you cannot get a good one. And this is the final step. You see all the screws are getting locked, and I'm decorticating it with a drill so that the ultimate layer of bone grafts can form. The final rod tightening and the decortication goes on simultaneously. And this is the bone grafts as well as local bone grafts as well as beta-tricalcium phosphate, and both are put as a multi-layered phenomena, multi-layered type in fashion while before closure. That is it, and this is how it looks like with the same patient. Thank you.
Thank you, sir. Thank you for an excellent talk and taking us through your surgical procedure, your thought process. Anybody, any tips, any questions? Amit bhai, Subir bhai, Thada sir is on.
Basu, do you take an AP X-ray post-op after your correction to see the shoulders or the correction that you have been able to achieve?
I have tried this, Subir, on many occasions, but there are two issues which always tends to question me a lot. I don't know the answer to this. First is, whatever you are seeing on the CR is a patient who is anesthetized, lying prone, and we all know whatever happens is when the patient stands up. So even if you're, for example, L2 is your lower instrumented vertebra and it looks horizontal. Now, once the patient stands up, what the L2-3 disc will behave, whether it gets tilted or not, this is something which is absolutely not always in conformity with your X-ray findings at surgery. Secondly, I think that horizontalization only can be realized through an intraoperative X-ray. But you cannot really that much understand the amount of rotation that you have left behind. And to me, the left behind rotation of the end vertebra or the low or the last instrumented vertebra is the key to behavior of the lower disc space. So for example, if you have left L1 horizontal but rotated, so immediately the L1-2 disc would not behave as if it was a good schoolboy. It would behave thoda sa tera. So yeah, I'm not in very much favor of taking intraoperative X-rays after my correction to do the final correction. Just sort of becomes a lengthy procedure and you are never satisfied with it. You do go on doing a little bit of correction here and there, which I don't think adds to more than 2% of the entire correction of your surgery.
Thank you.
Basu.
Yeah.
There are, it's very nicely narrated type 2 curve, all the intricacies. There is one problem sometimes which occurs, especially when you are correcting the proximal thoracic or severe type 1 curves also. And that is a neck tilting. Sometimes it occurs. And that you come to know only post-operatively. And then it's very difficult to, because you have corrected so nicely all the things, but the patient wakes up and you have a neck either on one side or the other side. So any thought process on that?
So as you can see in this video, the girl still has a little bit of left shoulder higher up.
Yeah, that's what I saw, that there is some trapezial hump which is still there.
And that trapezial hump is always due to the rotation of the vertebrae. If you have horizontalized completely, even if T2 is horizontal, here there is about a 10-15 degree tilt which is persisting, because if you look at this, the curve went up to T1. I initially thought that I might have to go on to T1, but I at surgery, I think I said, no, I'm not going to T1, because the more proximally you go, the more are they painful in their necks and the more are they have a possibility of getting tilted. So the neck tilt is something to do with the T1 and T2 disc space as well as the T1 and T2 angles. So as far as possible, try to make it horizontal. But again, there are situations in which the patient does have, even in the long-term follow-ups, a neck tilt. And that is the main reason when, even if there is a 30 degrees of proximal curve, I would neglect it. I would underestimate the trapezoidal hump rather than going up to T1 and risking a neck tilt. Because once you go up to T1, there is no further disc space to get it corrected. C7 T1 disc space is not at all something which you can hang around for. So they will have a neck tilt. So it's better to stop at T2 accept a little bit of trapezoidal hump, and rather than avoid neck tilt.
I think I completely agree with what Basu is saying, especially while managing idiopathic scoliosis. I think we are forbidden to instrument L5 and T1. Those two vertebrae probably are better untouched until you have an extremely strong reason.
Sometimes, as Bhavuk showed that he went up to cervical in one of that case. Of course, it was
no. That was not an idiopathic curve. There are special.
Probably
variants.
was not an idiopathic.
Yeah.
But when you apply force to the cervical spine, then it does not transmit to the thoracic. It all tilts cervical more compared to the thoracic. So it's better
Bhavuk has a comment to make. Bhavuk, please. And then we'll go to the next lecture. So
I think most of the point, almost all the points I agree with Dr. Basu. The only thing is that when I use hooks at the top, so I use the pedicular hook on the concave pedicle, and the convex side I use the transverse process hook. So that helps in derotation of the proximal, the end vertebra also. So that also gives a little bit better derotation and better trapezius, the control at the top, in my experience.
Can I just comment on that? You use the upper convex for the derotation part, or difficulty in putting the screws in the top part? Sometimes the two convex is difficult.
So putting screws is not a problem. The only thing is that it gives me a better distraction. It gives me leverage how to control the T1 tilt from that segment, because I can maximally distract and compress at that segment as per my radiographical control. And the other thing is, when I'm putting a particular hook on the concave side, so when my rod is coming up, so that segment goes up, and on the convex side, the transverse process hook, it goes down when I'm pushing the convex side down. So that also helps in derotation. You can see when you're correcting it, you can see it actually happening.
Bhavuk, that actually happens when the curve is quite a bit flexible. In this patient, if you see, there was a 62-degree proximal thoracic curve going up to T1, and with the T2-3 apex, this space being the apex. In those cases, whatever you do, it's difficult. But in those 40 degrees proximal curves where you can really manipulate it a little bit more, I agree that hooks are a good option.
great. So I guess thank you all. In a short of time, I think we are already slightly late. So we'll go quickly to the next talk. Dr. Suryaprakash now taking us through his thought process on Lenke 3. Over to you, Rao, sir.
Yeah. Is my screen shared?
Yes, visible. Yes, it's visible.
Yeah. There is a type 3 variant of Lenke idiopathic scoliosis. I think people have done an excellent job of explaining everything here. So briefly, I think Lenke's classification, how many other times you go through it, it sometimes is confusing. Sometimes you may have to see it again and again. No wonder in all those goniometers, it is printed. So every time you classify a curve, you keep looking at it and to see whether you have classified it correctly or not. Many times, yes, there is controversy. Some people might have a little bit of disagreement here and there, unless you have absolutely, strict measurements taken. Well, in this short lecture, I would try to make it very simple. Just review the classification, understand what is this type curve, look at the standard recommendations, and look at some case examples. Well, here, this is all we are looking at. It's a double major curve. In a double major curve, the proximal thoracic is a non-structural entity. And then you have to look at two structural curves. And generally here, the problems are fairly easy in sense that in any idiopathic scoliosis, when you have a structural curve, it is important that you fuse it. So in these Lenke type 3 curves, these are double major curves. The curve type reveals the least deformity from a clinical standpoint, because both tends to offset each other. Because when you see a patient walking into your clinic, they look fairly okay, but suddenly you see an X-ray, you see a double major curve. And thoracic and lumbar prominences can be noted on the forward bending test. And of course, both of them require posterior fusion. Well, in very selective cases, maybe a selective thoracic fusion can be considered. Well, apart from this type 3, 4, and 6, even 1C also we can place it here, so that these all are cousins and we need to look through them carefully before deciding what. But actually, according to me, maybe some of the panelists may disagree that a long-standing type 1C becomes type 3 curve. And these are the curves. Suppose when we dissect them out, we have the three patterns A, B, and C, especially a big long thoracic, lower thoracic curve, which is compensated by a nice compensatory curve here, can fall into 3A pattern, and then 3B and 3C are the common variants of this sort of curves. Now, points to consider: whether to do a selective thoracic fusion, what is the upper end and what is the lower end of the construct. Well, upper end of the construct also is decided. I think Dr. Basu has gone through an excellent situation where you need to look at the shoulders correctly before you plan, especially in an apparently right-sided major thoracic curve. When you have either shoulders equal or the left shoulder higher up, we need to be extremely careful in reassessing that, and then based on that, when we have a right thoracic curve with right shoulder higher up, we are very safe to going at T4. But when the shoulders are level, we need to be careful, assess intraoperatively and go to T3. And especially when the left shoulder is higher, that means there is not much of a correction in the proximal most thoracic curve. Then we probably need to go to T2 as Basu has shown. And coming to lower intermediate vertebra, actually here in this curve, because these are both are structural curves, we need to go either to L3 or L4. If the apex of the curve is cephalar to L1, L2 generally we go to L3, but if it is lower, it is preferable to go to L4. Well, the same criteria we can use in type 3C pattern, same as 1C pattern. Sometimes we can get away by leaving a little bit of well-balanced structural lumbar curve underneath. Sometimes if you can bring it below 30 degrees, it may not progress in the future. And of course, I think this was already covered in the first lecture, using of apical vertebral translation, apical vertebral rotation, Cobb's ratio. All these ratios are calculated just to ensure that the proximal, the main thoracic curve is the more structural one. And then in this case, when this criteria are maintained, we can get away by doing selective thoracic fusion, like in this case. Well, there is a structural lumbar curve underneath, but then as overall good balance is obtained, there is no problem. Well, these authors have given how they take an X-ray under the anesthesia to see whether they can improve the end vertebra to end instrumented vertebra to L3 based on by doing an X-ray under traction under anesthesia to see if L3 vertebra goes within this CSVL. Maybe I don't practice it. Maybe it's a good technique which we can all adopt. But then when I went through the literature to see really does it matter to that extent whether you stop at L3 or L4. Basically, there are some studies which say that it matters, some studies which say it doesn't matter to so much. But then always as a spine surgeon, as we save levels, we feel more happy. So we tend to do as less lumbar vertebral fusion as possible. And in summary, Lenke curve type 3 is a double major curve. Selective thoracic fusion, definitely not a situation in most cases, only in very select cases. Upper end vertebra based on T3, T2, T3, T4 based on the shoulder level, and distal end vertebra, whether it is L3 or L4, based on the various criteria we have already discussed earlier. Now you look at this particular curve, and here we have again on a traction X-ray, you can still see, and there is no question here, we need to balance the entire curve. We have to instrument from T4 to L4. Though in most of the idiopathic scoliosis, sometimes even at the lower level, even the L4 happens to be the end vertebra and rotated, we get away with a decent outcome. And this is a lateral film. This is another double curve with almost flat, thoracic profile. Here you see, though in the bending film, the lumbar curve is correcting well, this is a seriously structural curve. You see the rotation has not corrected an iota. So this has to be treated like a type 3 C curve, and then we need to go on to L4 and do instrumented fusion. This is a lateral profile. Again, this is another curve where it's a double major curve. Again, traction X-ray showing decent correction in both the levels. And then here we have gone to L4. And generally, you see my implant density is not that much. I tend to use strategic screws, and I'm fairly happy with these outcomes. And this is the lateral view of the patient. Again, another curve. Well, this could be a long-standing 1C, which has sort of 1A or 1B, which has become into type 3 type of a curve here. There is, again, if you look at the end vertebra, it is still rotated, but we are able to obtain horizontalization, near horizontalization of the L4 vertebra. So we are fairly happy with the outcome here. Again, we give the patient a decent sagittal profile here. Again, this is another curve where we went on to L4 and then proximal up to T4. And here you see this curves, especially when you have the right-sided thoracic curve apparently with the right-sided shoulder height, we can fairly stop at T4 and go for a really aggressive correction here, whatever is possible. Because post-operatively, we don't really face much of a problems there. And this is the sagittal profile of the patient. Again, another curve, again, double major curve here. There is a partial correction, and still you can see the structural changes remaining here. And then this, we had gone to, again, L4 here, we got a very fairly good correction. And you can just see the sagittal profile. And look at, see how there is a little bit of height in the right-sided shoulder is now nicely balanced post-operatively. Again, this is a curve with more kyphosis around here. Again, a type 3 curve here. Again, the lower one, you can see still there is significant rotation here, though the vertebra is horizontalizing. So we had to go to L4 so as to get a good balance of this patient. And this is the lateral view. Again, another curve, significantly rotated lumbar vertebra, but still on the traction film it is correcting well. But then with this sort of a AP picture, I'm not very confident of leaving it, doing a selective thoracic fusion. So we decided to go down and use it to L4. This is another curve, which we have instrumented till L3 here, and we got a fairly decent correction. Again, this is another type 3 curve where we had to go to L4. So again, another curve, you can see severely, these are all probably, as I said, long-standing type 1 curves, which tend to become type 3 over a period of time. There is a correction. I think still this can be argued as a type 1 curve. Again, here we had to go from the T3 to almost L4 here, and we had used 2 rods in this situation. Thank you very much. And here I've just showed you a lot of X-rays just to get the discussion out. Well, with my way of classification, there can be some difference of opinion between the panelists, and I welcome it. And because for all these X-rays, because I wanted to show more cases, I didn't put all the bending films and all associated with it. I just put a traction film. And thank you very much, Gujarat Spine Society and Dr. Niraj for giving me this opportunity.
Thank you very much, sir. Thank you for an excellent lecture. Any comments from the previous faculties, specifically type 1, type 2 faculties? Because there are few curves which can be classified into type 1 and has been classified to type 3, treated accordingly. Anybody would want to comment on that? Would you Bhavuk, would you do the same thing? The long type 1, type A 1?
As Dr. Surya said, that everybody differs in his approach.
Yeah.
So maybe I will do it differently. My question to Dr. Surya is, sir, in some cases, the L3 and L4, they are almost the parallel to each other. So they are the end vertebra. The L3 is also the end vertebra, and the L4 is also the end vertebra.
Absolutely.
So what's your LIV in those cases?
Generally, whenever possible, I tend to go to L3 but then sometimes I feel that I may be taking a little bit too risk. I would go to L4 because see what I have seen is my because I would say my practice has been in two types. For the first 10 years of my scoliosis journey, I was working in an institute where costs and the issues were not a consideration. But now in private setup, patient, if there is a decompensation or anything, patients are not really happy. So I tend to give the best possible shot, and patient doesn't want resurgery or extension or adding on at any possibility. So sometimes when the patient, I feel they are a little fussy, and then we know that yes, there could be, you can stop at L2 or L3. I tend to prefer L3 because, you know, we don't want, you know, more issues cropping up with. I mean, I won't say this is absolutely scientific. I would say this is a sort of a practice option, because when for my personal you know, quest, I have gone through the literature to find out whether it makes such a big fuss whether you stop at L3 or L4. I mean, hardly there is any literature. In fact, in the Harrington era, when there was usually distraction is the only methodology used, and then the junctions were really a problem. Agreed, there might be a situation, but now with almost near normal contours, we are giving bit back. I'm somehow not very, you know, fussy about leaving one vertebra this way or the other. Definitely not to L5, but yes, L4 or L3, I have no so much of, you know, worry about.
Okay, so yeah.
Suryaprakash sir has quoted a paper on mammoth. That classification is beautiful, and that points are very clear that it very closely resembles the CD points. The CD points or the isola principles, if followed, they never fail. Lenke's principle, all other principles have some add-ons or some failures, but the CD principles and these isola principles, they don't fall. They never fail. So this mammoth is very near to CD principles, what sir quoted for L3 and L4.
All right. So if there are no more comments, I actually wanted Ranjith to come in. Ranjith, are you there?
Yeah, very much, Niraj. Yes.
So let's take your opinion on this. You know, I mean, there are certain borderline areas in Lenke Type 3. How would you think about it?
So I will talk on the lines of what Dr. Surya sir mentioned. You know, when your early part of practice and your later part of practice, earlier part of practice in an institute setup, you want to try saving levels, all sort of heroics, etc. When you come into your private practice or your longer follow-ups, you edge more on a longer segment and, you know, more correction than a resurgery. So today I'm a bit liberal when it comes to saving levels. If I can save to L3, blank, no questions. When it comes to L4, if go to L5, I try to squeeze to L4. But again, I very clearly tell the patient that no, this is what we do. We can try. There is a possibility of adding on, etc. And the reaction immediately is, doctor, we don't want another surgery. Do what you want. It should be one shot. So I go to L4 and take everything possible to derotate and try to match it. And that is my talk. That is my take there. And all these classific, etc. You know, roughly they all give you very good guidelines. If you see now what Dr. Ajay mentioned, you know, going to mammoth going back to isola starting at CD. So it's all kind of getting a circle. I will not exactly agree that Lenke is not reproducible, but there are ifs and buts and a lot of modifications of the last LSTV, you know, and the 1A, 1R. They all really give more adding ons to more inputs into trying to get more predictable corrections. That is my take on it.
Can I add something? Can I stir the honestness?
Yeah,
know,
please.
I agree that in coronal plane, going to L4 gives you the best coronal profile. But now people are talking about that the L4 is the apex of the sagittal curve. L4. So you are ending your instrumentation at the apex of the sagittal curve. So again, you know, and we know that all the pedicular screws, they are actually kyphogenic, whether you use this thing. So again, you know, this is creating a long-term debate.
Exactly, Bhavuk. So when you sit and look at your own, where you stop at L3, L4, today I try and see wherever I have got those went to L4, etc., where I feel it's not good. It is my technical failure of not doing a good Pontes and correct it. I totally agree with you. I don't do any osteotomies for AIS today, other than for congenitals or for revisions. All I can safely manage in a posterior column, and I strictly don't do any anterior for scoliosis now. No anterior at all for scoliosis now. I mean, I know I'll be vehemently opposed by all the radical anterior surgeons, but I think, I'm a reformed smoker. I am a reformed anterior surgeon now. I don't want to do anterior for scoliosis now.
All right, I guess, in the interest of time, we will quickly go to now triple major. Lenke Type 4, may I invite Dr. Amit Bhai to enlighten. He is a person who works also in private and also in institute. So I guess, let's not get biased by institute or a private, and let's hear what he says.
Okay. Thank you, everyone, for coming to our SAG. You can see the screen, right?
Yeah.
Yeah. Okay. So what I'm going to talk is actually a hodgepodge of whatever has been taken, because I'm going to talk about 1, 2, and 3, whatever already has been taught by Bhavuk and Basu and Dr. Surya, because 4 comes as 1, 2, and 3. All the 3 are major curves. Okay. So, and if we see the literature about it of type 4, the type 4 has, as I said, it's a proximal thoracic, main thoracic, or thoracolumbar curve. And it's the least common and the rarest of all the AIS that we have seen. And in my practice, I was just going through all the cases that of AIS, right from last 10 years of AIS. And there are very few cases of type 3, actually type 3, that I have come across. The incidence, as in the literature also, is very less. It's around 1.4 to 3% of all AIS. And it was in Lenke's original series around 2.5% from 315 patients. So to see in a routine practice, of course, off and on, you can be lucky to get these type 4 curves. But most of the time, what I have seen, they are as a neglected curve pattern, as Dr. Surya told, that either 1, either 2, or 3, if they are neglected early onset ones, then they will fall into the category of type 4, because the compensatory curves which are there of the proximal thoracic and the lower thoracic will again become rigid, and then you have a triple major curve which comes. So it's a development of triple curve, can be either at a presentation, and which a very juicy case, that if you have this case as a presentation at 12 or 13 years as a primary presentation, then it's good. But usually what we see is during the progression where the compensatory curves become structural and progress. So it can be either single, double, or progress, the triple major curves. The majority of time it is accompanied by the lordosis, because they are they are accompanied with the lordosis, because they are actually type 1 or 2 curves which are going into type 4 curves. The natural history of type 4 curve is absolutely poorly understood because of the rarity of this, and we don't have a long-term follow-up of anywhere it is available for the natural history of type 4 curves. But idiopathic type curves have benign course, and mostly they are balanced because all the 3 curves balance each other. So this is what is the primary thing for the type 4 curves. But the type 4 has the greatest percentage of the larger curves, because as I said in this article also, they have said that 52% of the curves are more than 75, or average mean magnitude is around 80 degrees. So type 4 curves are neglected curves, and they have lower SRS outcomes. The curve characteristics, it can be either 4A, 4B, or 4C. But it's very, very important that if you see these 2 curves which are there, and you have to measure all the 3 curves. Unless you measure all the 3 curves, you are definitely going to miss, as Basu said, that if you don't measure the proximal thoracic once, and if you just eyeball it, then you are definitely going to this proximal thoracic curve, you are definitely going to miss. If you see this curve, this is where it's a double major. But if you see this curve, if you measure it, it is 68 proximal thoracic, 124 is the main thoracic, and 40 is the lumbar curve. So you have to measure it very, very well, and that's what for this is for actually for the juniors, and they should measure and find out that there are 3 curves. Never see that this is only 1 or 2 curves. Actually, there is a 3rd curve which is there here, which is sometimes missed. You cannot see this curve sometimes, and you may just think that this is 1 curve of main thoracic and this. So it's very important that you measure these curves perfectly, and equally important to measure in bending to exactly classify them. And this was a definition which is already spoke about before, so I'll not go into this definition. And this is the same what Dr. Suryaprakash showed, that these are the 3 curves, but the only difference in 4 is you have to look for the proximal thoracic, and you can see that the T1 is tilted to the right side, and therefore the shoulder on the left side is higher up compared to the 3 and 6 curve, where the shoulder is either level or it is on the right. So how we have to look absolutely clinically also, whether the shoulder is level or shoulder is high on the left side, and that will give you the whole idea. So this is an adolescent type 4C, which is it's very well balanced. You can see 40, 68, and 57, and this is primary adolescent type of 4C. But this is very rare to see. But this is what we so many times see, that neglected ones which have progressed to, and you can see it's a 120-degree curve of the main thoracic, 95 of thoracolumbar, and 34 of the proximal thoracic. So these are the curves which are difficult ones once you have these neglected curves, and this is what we are going to face. And you need to fuse all the curves. There is no way that you can leave any of these curves. So if you see clinical characteristics of Lenke 4, which are very important, and main thoracic curve is there, so you will get a right side rib hump. Thoracolumbar and lumbar will give a left side lumbar hump, and proximal thoracic, as I said, you have to look at the left shoulder up. It's not always so, but majority of the time, if you have this, then you will find that this is the triple major. So if you see this case, there's a scapula which is prominent, which shows that there is a right side rib hump. There is a lumbar hump here, and you can see that this shoulder is elevated on the left side. So this is a clinical criteria that you need to see, and you can fairly say that this may be having a proximal thoracic element along with the other 2 elements. You have to classify again for A, B, and C, and whether you have to assess whether it's a minus, neutral, or sagittal. But considering the general principles of treatment, you have to treat all the structural curves, and they all 3 needs a fusion. So Lenke 4 curves are triple major and requires fusion of all the 3 curves. I don't think that there is any option of selective thoracic fusion unless the lumbar curve is very, very flexible. Then only you can go for the selective thoracic fusion. So this is what I actually follow for any of the principles. I don't see the classification, but this is what I follow routinely as my selection of the fusion levels. I would go up to the neutral vertebra and vertebra or neutral, and that is what was taught by Bhavuk also, that you go up to the neutral vertebra wherever it's possible. Lower end of the fusion should go up to the stable vertebra, and you have to see the lateral X-ray and include the there is a kyphosis. You have to include that part also in the curve, and you have to see that opening of the disc space in both the bending films, and then you select the LIV and never end the apex. So these are the general guidelines that I follow. Now there are some rule changes to this, which are there, which has already been discussed. Now, how to select the fusion levels at the upper end? I go up to neutrally rotated. I see the parallel disc space above the upper instrumented vertebra, opening of the disc space equally in both bendings. And this is what everyone follows, that T2 if left shoulder is elevated, T3 if shoulder level, and T4 if right shoulder is elevated. Again, for the lower end, I see that neutrally rotated vertebra, parallel disc space below LIV, opening of the disc on both the sides, stable vertebra, and lumbar modifiers. They have a different criteria. So this is what the case was I'm going to talk about. The female 12 years, Imanacal, recently detected since 1 year, research 0. And you can see this is the curve. It's a fairly simple curve, but it's decompensated to the left side. There is a proximal thoracic curve of 30, main thoracic 56, and lumbar curve of 50 degree. So this is, and you can see that there is a kyphosis of 16 degree. It's very difficult to sometimes measure this kyphosis because of the problem of the X-rays. So I always try to get the CT scans in whenever there is a problem, and that gives me a fair idea whether it's a lordotic, or even these curves are very well nicely depicted with the CT scan. So this is what my routine is, that I get whenever the patient needs a surgery, I get a CT scan in all these patients so that I can evaluate them very well. So the question here is, this is the thing. So proximal thoracic, which was 30, which bends to 16, again a non-structural goes to a non-structural. If you see this thoracic, which was 56, goes to 21, and thoracolumbar, which was 50, which goes to 24. I don't know how to classify this patient. Whether it's all three are non-structural, all are considered as non-structural because they go below 25. So you can treat them by brace, but you can see that clinically the patient had a problem and issues. So we had to operate because the patient had that issues of the hump of the thoracic as well as the lumbar hump, which was troubling them. So the question is how to select the fusion levels if surgically treated, and should we fuse all the curves because all the three are there and all the three are non-structural. So what should be the UIV? What should be the LIV? Should we, if it is, should we stop at L4 or L3? And this is what was already discussed before. So all these points are already discussed when to include the proximal thoracic curve. But I say that if the clavicle angle is not normal, shoulder is normal, there is no tilt here, and bending is less than 20 degree. So I thought that I'm not going to fuse this proximal thoracic curve and leave alone. So T4 was taken as UIV in this patient. And if you see whether to go for, and this is what I think Dr. Suryaprakash was also talking, whether to go for L3 or L4. But this paper has said that the severity of the pain is increased with fusion that ends at L4 between 62% to 82%, compared if you stop at L3 where the pain is only about 30 or 39%. So actually these cases should be left unfused, tending to fuse less in lumbar spine, not only for this degeneration but also for the movement, and that's very important in our setup also, where because the patient do ask if you go more into lumbar spine, their movement is restricted, and therefore fuse as less as possible for the movement also over and above this criteria. So these are the clinical evaluation. I am not going to go, but this is the same paper which was quoted by Dr. Suryaprakash, and in this patient particularly, I used not true Truga, but I use this criteria on our traction films. And these traction films, if you see that this was the patient, you can see it was 50 degree lumbar curve. And if you see CSVL, the L3 is far away from the CSVL. It also is far away from the Harrington stable zone, which is 25% of the L3 is in the Harrington stable zone. So if you just look at this, but if you see the traction view, you can see that CSVL, you have L3 as the last touch vertebra, and you see that 75% of the L3 comes in the Harrington stable zone. So I use that criteria of Truga, which was quoted by in the previous paper, and I took L3 as a lower end vertebra in this patient, lower instrumented vertebra in this patient, and this is what I got with correction. I left the proximal thoracic curve, I even left below and just went up to L3. There is some tilt there, but on the whole, the patient is quite happy in this. So we got a fairly good correction. You can see that all kyphosis and the other we had a very good correction. So LIV was L last touch vertebra -1 in this patient, and this is what clinically the patient looked like, and you can compare the pre-op and the post-op images of the same. So this was one case where it was an adolescent and onset of type 3 curve. And now coming to the second case, this is a neglected pattern, and it's a female 14 years severe deformity, shoulders level or right down, left pelvis up, severe deformity. I'll show the clinical pictures, and you can see this is a very severe deformity. And if you look at the hip and the chest wall are just touching each other, and there's a very big rib hump, razorback like there. And if you see this X-ray, then this is what it is: 68-degree proximal thoracic, 124 degrees of the mean thoracic, and degree of the lumbar curve. And you can see, and this is what I say always, that I get a CT scan, I don't exactly know where to go and where to. So I always get a CT scan, and that's so it was a hyperkyphotic type of deformity of a triple major neglected curve. So what we did, the flexibility, these are the bending films. From 124 it came to 99, 68 came to 48, and this is 27. So compared to the lumbar, the proximal thoracic and main thoracic were quite rigid curves, and the main thoracic flexibility was around 19.5%. That means it was a fairly rigid deformity. So what was the plan? All the three curves to be included, definitely. Fusion from T3 to L4, because shoulder was level. I just wanted to stop because you can see that the shoulder was level here. So I just wanted to stop at L3, sorry, T3 for the upper curve. Because it was a very stiff curve, I usually stage them if I am doing an osteotomy. So this is what I always counsel the patient beforehand, that if we require an osteotomy, or if the time goes on, if there is any more bleeding, then I will just stage it. I plan for an APSO with multiple contis, convex side first, instrumenting, cantilever type of correction, counseling for all possibilities, and neuromonitoring must. So these are all the routine things that I do for all these rigid curves. So in the first stage, I just instrument and release all the facetectomy. I do contis and put in all the screws. I was not able to put the screws in T3. It's difficult to put the convex D, and I just did not put the screws here for T10 osteotomy at a later stage. And then what we did after, I think, 3 or 4 days, I usually take the patient back. And you see, I was not able to put T3, so I had to go up to T2 on one side and T3 on the other side. But this is what a good correction I got: a 56 degree, 59 degree, and 12 degree at the lumbar, and a very balanced spine. Even the hyperkyphosis was fairly well corrected. So we got about 52% correction of the main thoracic curve, which was a fairly rigid curve compared to the other ones. So this is what I did in this patient, and you can see the comparative view of this, and this is what the pre-op and this is the post-op. See, that's hyperkyphotic, and it has some fairly normal kyphosis, and that's a clinical picture. And the patient was doing fairly well after this. So the take home is idiopathic Lenke type 4 is very rare. Idiopathic type 4 are balanced curves and benign if they are purely idiopathic, but the neglected curves progress. They require definitely intervention, and they are very difficult to treat. Important to measure all the three curves, and selection of fusion levels follow the same general guidelines as we discussed. And the correction maneuver usually is hybrid in this patient. Thank you very much.
Thank you, Amit bhai. I think, just one quick comment from Dr. Basu, if any. Otherwise, we'll go to the next speaker because we are already running out of time.
Well, I think for the paucity of time, Niraj, we should progress.
All right. Then I think, may I invite Dr. Ranjith to come up with his Lenke type 5. So far we only discussed about saving fusion level. Now we come to the curve where, lumbar spine is most affected. So let's see what Ranjith thinks and what Ranjith does. Ranjith, over to you.
Niraj, can you hear me?
Yeah, we can.
Okay. Can you see my screen share?
Yeah, we can.
Okay. Thanks so much, Niraj. Very glad to be part of the SAG in a good way. Thanks, President. Let us go. So after all these excellent talks about 1 to 4, let us come to 5, in which there is not much about much of a controversy as to UIV. It is about which way to tackle it and what is the lower level. So just to is my slides moving? Are my slides moving?
No, it is not. It is not moving.
Okay.
Yeah, it moved. It moved.
So this is the most important part of all our corrections. The most important thing is not the part which we fuse. What really matters is the unfused area. So how we can match the fused area to the unfused area decides the harmony and the functions, the HR, QOL, and all those things. Now, just to know these critical points of all the expert speakers already mentioned all these things. That is good planning, generous soft tissue and bony release, strong anchors on strategic vertebrae, a very appropriate correction maneuver, and trying to restore the sagittal balance, and most important, achieving a solid fusion. These are the 6 principles of any surgery. Now, what is the crux of what is specific about type 5? Well, the UIV is going to be the UEV. That's more or less clear. So the UEV as the upper end vertebra. The whole catch is in the LIV selection. So all discussion between front, back, etc. has come from the selection of the LIV. So the idea is to save a distribution level. So if you want to stop at L3, that is not a big thing. You can stop there. The question is 4 and 5. Why? Why is it so? Because we all know that if you can really stop at 4 or 5, you will really get 73%, 75% of the lumbar mobility if you can stop at L4. Now, we are all familiar with the standard pros and cons of anterior to posterior, shorter segment, saving levels, better rotation, etc. Now, the question is it really relevant in today's scenario and today's literature information? I'll like you to get your address to this review in published in 2019 Spine Journal, where 50 papers was reviewed on type 5 Lenke between anterior to posterior. The outcome was that the anterior and posterior both demonstrated very similar satisfactory outcomes. Now, if you dissect the paper, you come to this point that the average LIV angle became worse immediately after anterior procedures and progressed on final follow-up, whereas the average LIV angle on the posterior procedure stayed put. So that probably is that we have more predictable corrections with posterior instrumented correction. Now, we all are very familiar with the stable zone of Harrington. We all want to say that all our instrumentation should come and stop at this stable zone. If not, they decompensate. Is it really true? This was on the era of Harrington. Today we've got more powerful derotation instruments available, more better techniques available. So should we really think of all these things when we plan our today's strategy? Now, how do I select my LIV? For me, these are the most cephalad vertebra touched by the CSVL. So this part of the lumbar curve, this is my first point. Next, less than 1 degree national vertebral rotation, meaning not a very rotated vertebra. It should not be at the apex of the kyphosis, what Dr. Bhavuk mentioned. I try and go down, not above. The CSVL should cross between both pedicles on the concave bending film. So here, the concave bending film in a type 5 or a 6 is the catch, because you know that there might be costopelvic impingement on a lumbar curve, which might really not let you be able to bend it really well. So that is taken. That's why we have to look at multiple features when you decide this point. Now, in this, the CSVL, I use the King CSVL, not the SRS CSVL. You see that the King CSVL is bisected right angle at the iliac crest bisection, whereas SRS is the plumb which you drop down from the sacrum. Now, this has been validated in this paper published in 2020 from PUMC by Professor Zhang, who I might spend some time with. So they have a long-term follow-up of 13 years that this way of LIV selection has to be found to be predictable. Now, I will not stand in argument between this car and this car. I'm just like mentioned some time back, I'm a reformed anterior surgeon. I cannot accept these cars today. I have patients who come back to me all my earlier sins. They come and show me this car and then I really feel sorry. And today I have this car on the right side who are much more happier with same amount of comparable results. Now, what is the real prerequisite to this correction? It is an adequate release, strong anchors, and a solid fusion. Now, this is the most important part for me when I do a type 5 curve posteriorly. It is a generous faceted release, whatever you can call it, posterior column osteotomy, Ponti's osteotomy, whatever, taking out the supraspinous interspinous ligament, complete posterior release, and the most important thing is to osteotomize the spinous process very well, because you know that you are trying to lordoze the spine. So we're going to shortening the posterior column. So the spinous process should be released so that they should not hit each other when you correct. Now, all these things have been mentioned by the previous speakers. I'll not go through all these things. Now, in type 5 curve, the most significant parameter what you use is actually convex correction, because apart from doing all the type 1, 2, 3 curves, in a type 5 curve, when you do it posteriorly, you have to put all screws on the convex side. So it is like a type 5 anterior. You do the exact thing posterior. You put all the convex screws, no sparing there. On the concave side, I just put 4 screws. One at the end vertebra and 1 or 2 at the apex, because my primary corrective force is going to be cantilevering force. I put the convex rod first, and that really corrects it. And if there is any residual rotation, I bank on the rod rotation to get me my sagittal profile, because I want lordosis here. So I attempt it only after I do an adequate bony release. I don't go and push my rod and try to get the correction. So this is exactly the derotation what you do for the thoracic spine. And here, the convex rod does the maximum correction. Unlike in a thoracic spine, the convex rod does the maximum correction, because that is my correcting rod. Concave is a neutralization rod. This, apart from that, I also bank a lot on the vertebral rotation, so that I get my lordosis correct and I get my lumbar hump down very well. Only these 2 osteotomies, out of which the PCO is the one which you use maximum, rarely a discal osteotomy in case of a revision surgery, which is not the purview of this discussion. So let us go through, and thanks Niraj for this thing. I sat a chance to go through all my really long-term type 5. So this was a patient, typical type 5. So I applied my concave rule, that my LIV had to be L3. Went ahead, did my L3. This is the immediate post-op X-ray, and this is the 4-year post-op X-ray. If you see very carefully, you can see that there is a bit of discal wedging, and then it stays put like that. Another case, this is a very really a long-term follow-up done in 2010. So I look my concave CSVL told me that my LIV had to be at L3. I went ahead, did an L3. The immediate post-op standing looked like this. I was not very happy, but on a 10-year follow-up, she's holding on. I stopped at L4, and the correction holds on. Another case operated in, I think it was in 2011. So this was the pre-op standing and lateral bending X-rays. I did my concave CSVL, so I had to stop at L3. This was my immediate post-op X-ray, and at 2 years, I think she was slowly tilting, but my discal wedging was still maintained, and I have a really 11-year follow-up on her. I'm keeping my fingers crossed. My L3 still holds on, but I am getting gradually progressive wedging of the distal disc. She's still clinically balanced, and I'm holding on her. Another 15 years of lady. This was very interesting for me because it looks very easy. Looked very easy to me. I thought it's a cool cake, but in this patient, intraop, I lost signals. And I had to end up doing an undercorrection. You can see that there is no lordosis given at the lumbar spine, and you can see the rod is still bent. But on a long term, this was her follow-up, and she kind of balanced out in the long term. And this is a 10-year follow-up. She still holds on, has no symptoms. All of them are clinically coronally balanced. Sagittally, I know that it's not a good job. Another lady, again, interesting one. I did her in 2007, and she was 16 then. She was a very heavy 16, the curve was there was too much of rotation. I did my concave. I thought I'll go and stop at L3, but I was not very sure. When I discussed with her, she was not very willing for anything. She told, no, doctor, I don't want another surgery. And unfortunately, she had another surgery because I went at, stopped at L4, and post-op, she had a foot drop. She had a foot drop because if you see very carefully, one of my screws was going down. So I took her up for revision. I changed the screw, did not change my levels, and this is a 14-year follow-up on her. She's still holding well. This is my 14-year follow-up. There is a good sagittal balance and coronal balance. Another case, all similar type 5, I'm very vehemently go and stop at L3, long-term follow-up at 7 years. There is discal wedging, the spine is still clinically balanced. So this is a very interesting patient for me. She was I operated her when she was 29 years of age in 2014. She was a Bharatanatyam dancer. She was a professional dancer, and at any cost she wanted to maintain her lumbar spine mobility because Bharatanatyam is a very, as we all know, it's a very dance. So I went and stopped at L3, and I have a 6-year follow-up on her. She actually has got me many dancers with scoliosis, interestingly. And this is how she very sagittally coronally balanced back to her profession 2 months post-op. Another operating in 2013, she was 15. She's 15 years of age. All these, I'm a kind of reformed anterior surgeon. I go and stop at if possible at 3 and never try to go behind 4. In 2013, this is an 8-year follow-up, still balanced well. Again, similar patient. Concave. So this is, so you should also see the complication. So this, I went ahead, I did my concave CSPL. I was to stop at L3. There is residual rotation was fine, less than 1. So I stopped at L3, and she was, this was immediate post-op. I was a bit scared because immediately I saw the discal wedging. I kept on follow-up. This is a 7-year follow-up. You can see that the discus wedging, the distal vertebrae is neutrally rotated. And I have told her that if she adds on further or she clinically compensates, we'll go and revise. But she says, I have no problem with holding on. I saw her last, I think this year, 2020, last this year. Another patient, again, a type 5, severe vertebral rotation. I draw my PSP concave. I have to go and stop at L4. So I stopped at L4. This is the immediate post-op. This is 5 years post-op. Very well maintained coronal, and this is also another Bharatanatyam dancer. Again, very well maintained sagittal and coronal balance. Another patient again, type 5, 1 year post-op, went and stopped at L3, 5 years post-op. If you see her coronal sagittal balance, this was the pre-op. Sagittally had a kyphotic spine. Post-op at 1 year 2, she's still kyphotic, and this is her X-ray at 5 years. I think she's probably looking forward, but clinically she looks okay, and I'm keeping an observation. Another similar patient, all type 5s, go stop. I go and stop at L5. Whenever possible, try and stop at 4. If nothing, go to 5. Another one, 6 years post-op. For the want of time, I'll skip through all these slides. Again, another one immediately post-op, long-term post-op. Now, again, 3 years post-op. Whenever possible, try and stop it. I do anything and everything to derotate the distal end vertebrae. Do a very good convex. So if you see I've got all screws on the convex side because that is my correcting side. On the concave side, I only have 4 screws, both at the end vertebra, and if it is a disc as the apex, I got 2 vertebrae there. Now, I personally feel that the Dan saving level, when you do a type 5 on the back, you have to really take efforts to release properly, lordoze your rod properly, and derotate properly. You get same results at the same levels as you do from the front with a very shorter hospital stay and a better scar. So what is my strategy in type 5? Always try and do posterior spinal fusion. My UIV is my upper end vertebra. LIV, if comes to L3, fine, no, great job, go ahead. Always try and stop at L4. If nothing else possible, go to L5. Do adequate release. I do a posterior column osteotomy in almost every case. I take off and I do an asymmetric osteotomy. I do more of convex release than concave release because that is the shortening side. Put the convex rod first. That is your correcting rod. Do rod rotation and direct vertebral rotation. And you have to paralyze the disc by compression, convex compression, that is your caudal disc. Make sure it is parallel. and you have to have a general. Thank you for your patient listening. Any questions?
Thank you, Ranjith. Any quick comment from anybody?
Yes, sir. Ranjith, one question.
Yes, sir.
Everything is okay about the LIV, that's fine. But have you, because you have a long-term follow-up, supposing the curve goes up to D6 or D7, have you come across PJ case in AIS?
Sir, yes, sir. So they will technically go into type 6, sir. When I see the ones that are really kyphotic, I don't call them type 5 anymore, because a kyphotic dorsal lumbar junction, if you stop at 10, you get PJ. I have PJ cases in AIS where I stop short. So in them, I go to D4. I go to D4, sir. When I see these kyphotic DL junctions, or I see a very hyperkyphosis of the thoracic spine as compared to lumbar spine, I go to D4. And for me, they are no more type 5, they are type 6. They are type 6.
Yeah, but sometimes you see flexibility, then they will be flexible at the upper thoracic, the thoracic ones.
More flexible.
But still,
D4.
yes. But
More
still,
flexible D4.
yeah.
D4, sir. Because I had my share of PJ when I go on stop at D4.
Okay, so I guess, we'll quickly move to last talk. Dr. Ajay, you will have to share your screen. So Ajay is going to take us through Lenke type 6, and that will be the last curve for demystifying Lenke's classification. Over to you, Ajay.
Yeah, nothing much left there to be discussed, but still. Now, type 6, almost everything is covered, and this is just a type which is different than others. I'll just directly go to the case because most of the theory has been discussed. I've just removed the slides. So it's a 17-year female, post-menacal deformity of the spine is the first observation in the last 1 year with shoulder asymmetry, right shoulder up. Cosmetic concern has been the main concern, and the neurocutaneous everything examination is completely normal. And this is what her standing X-ray with the right shoulder, which is just up. This is the curve which is lumbar. This is the thoracic curve which is there. These are the bending curves which is there, and this is your Adams test showing the thoracic hump, the loin lump which is visible there. So this is the crease which is there on the side, and she is fairly balanced. Now talking about type 6, this is the curve which we are talking about, and we all know that these all have all modifiers, but 5 and 6 don't have any modifiers, and it is directly the C type. So it is 5 and 6. There is a lot of thing. What happens is that 6 is many times confused with 5 and 3C and aggressive Cs, and even literatures it is quoted frequently as 6, though they are not 6. Coming to this patient's frontal view X-rays and measurements. So this is a cob with a lumbar curve which is 69.3 and a thoracic curve which is the MT is 58.9, and the kyphosis is 34.1, and at the same time lordosis is something which is 62.7, and that's a 6CN. It is 6N can be called, and these are the parameters for the same, and the riser is 5. If you talk about pelvic obliquity, it is within range. It is manageable, 6.5. If it is ATR, if you are talking, then it is 2.1. So the flexibility of the lumbar is more than the thoracic. And if we are talking about the apical vertebral rotations, then again it is flexible on the lumbar side. Side bending radiographs taken. So the thoracolumbar 69 corrects to 48, and the main thoracic correcting marginally. It's not correcting much. So as talked earlier, also many of the cases there will be costopelvic impingement which would prevent any of those corrections of the main curve. So that may mislead you. For planning of for the surgery of this patient, apical vertebra being L12, the neutral vertebra, the lowest end vertebra, and the stable vertebra all was taken into account for the planning of the lower end, and the upper end remains the same. It is the upper end of the upper curve. So it is T5 here, which was taken for this case. At the same time, for the lower, this is the last touched vertebra, which happens to be the end vertebra, as well as it happens to be the neutral vertebra. So L4 was taken as the lower end vertebra, and the surgical execution had been directly for staggered through from D5 to L4. Pontis was liberally done for lumbar, but the lumbar was correctable significantly, but the Pontis were done more for rotational derotation and fusion, not for correction of the frontal top. The right rod in the thoracic spine, a shorter rod I use for the thoracic hump to be corrected. That's a temporary rod which just pushes the hump down, and the kyphos is there, and the cantilever rod rotation and in situ bending and restriction compression is done as for any other curve, and there's no excess lumbar curve correction I attempt, because if I would have corrected a lumbar excessively, then I would have made the dorsal more prominent or the thoracic more prominent with the right side up. So that was the thing I wanted to control it to a certain level and not go beyond a correction of say 40 to 50 degrees of percentages of correction. And the maximization of the derotation of the lower vertebra was achieved as Ranjith also talked, and the posterior fusion and double rod was I used. In many of the cases I used this double rod. This was the final correction which was achieved, and the correction was the thoracolumbar corrected from 69 to 37 degree and the MT corrected from 59 to 30 degree. So this I under corrected so that I can have a control, because the right shoulder was up. So that was the reason why I wanted to do it, and I achieved a fairly good kyphosis and lordosis. This was her immediate clinical picture, and this was the overlay, and follow-up clinical was this. She behaved well. I use a traction film I just mentioned, because instead of bending I use the traction films, and that gives a fairly good idea. But at the same time, the type 6 curves, what has to be looked upon is the significant rotations in the lumbar curve. These are the rotations which should differentiate your curve from the C of the 1, 2, or 3, what you're talking about. So this is what is important, and traction films give. Whatever has been achieved in a traction, even if you achieve that, that is enough. So that comes into the Harrington zone of stable zone of Harrington. This is Fischer's classification, wherein they would use for selective fusions in 5C and 6C. And the ratios between AVT and AVR and the Cobb angle measurements, if they are more than 1.25, they would consider a selective fusion. At the same time, the thoracolumbar kyphosis has to be less than 10 degree. That is the criteria what they use for the selective fusions. So I didn't do a selective fusion because being Lenke, I did from T5 to L4. But you can selectively use many of the cases. If in this case, 6C, see the ratio, if you calculate it is going 2.1 and 2.7, you can very well go for a selective one, but you won't do it. The reason was that the thoracic curve was correcting to 59 to 58.1 only. So that is the reason. It has to be less correctable, then only you can think of a type 6 curve, a selective fusion. So here I went all out. And these cases are very less what you do. And say you every 2 to 3 years you get one case of actual 6. You may mix up with your cousins, as Suryaprakash sir said, because they are not 6. They are not 6. This is what was there, and this is what we could achieve, and this is the final picture what we could achieve. And these are even best of the literatures. If you go into, they mention these sorts of curve as 6. They are not 6. It's wrongly confused. And these are type 5 curves. They are not 6 curves. This is again another curve. This is another paper which is talking about Lenke type 3C and 6C, and they talk of stopping at the apex of the lumbar curve, and it works well. Now, when you go into the details of the article, each and every image is 3C. None of the 6C image is there. So the literature itself is misguiding you in many of the curve selections. This paper has been quoted already by 3 people in this talk. So it is Mehmet's way of deciding on traction EA X-rays. This is very well, and this is very near to CD classification, and CD is the best. You don't fail on that. You make a construct. To make it more complicated, three curves we have all been talking about. There's something on the fourth curve also, the transverse plane pelvic rotation, that is already there, and that may increase or decompensate. These are not noticed, and they don't make a big difference to the clinical outcome. That's why it's not talked about, but soon it will be talked more. Thank you. Thank you very much.
Thank you, Ajay. I think, with that, we are at the, and I think, before we depart, just want to add a concluding remark to this. As you have listened to all the faculties, there are a lot of gray zones in even classifying the Lenke curve. So it is always very much important how do you try to balance your spine. So balance of the spine is the most important aspect one should remember while dealing with their UIVs, LIVs, and what kind of procedures you would want to do intraoperatively. So before we close, just I would want to listen to a quick concluding remark from each of our faculties. We start from top to bottom, Lenke 1 to Lenke 5, and finally we will just close the session. May I start with Bhavuk? Bhavuk, just concluding remarks.
I think the most of these classifications, they just guide us to, they just give an idea that how to approach a particular problem. So, Lenke classification is not absolute. We have to look at, what are the problems associated and what are the solution to. We have to think of novel solutions, and then only we can enhance our understanding of this complex problem. And that's how we should take as the Lenke classification, and nothing is absolute.
Dr. Basu sir, your concluding remarks?
Literature confuses us more than what we get ourselves confused. So take evidence from literature, but rely on your experience and sixth sense.
Thank you, sir. Dr. Rao, sir.
This Lenke classification has been helping us definitely, but then there is one good thing about it. Though we say major, what runs behind in the background is the word primary. As we have read through King's classification, we started always thinking what is a primary curve, what is a secondary curve. That is what is the usual thinking which goes on in our mind. Though this terminology, primary and secondary, are dropped, this, though we say major, I think as we look at it, we try to look at it more like a primary curve. So that the problem again with these classifications are, it is a particular snapshot, a particular curve at a particular point in its life story may start as a type 1 curve. Sometimes it may land up with type 3 or even type 4. We really don't know, because at that particular time, that is how it is going to be, because all these curves at some stage they are held and they are all operated. So we exactly don't know what would be a natural history of each curve, and obviously such a study is not possible. I think I completely agree with Basu. We must just understand the classification and ensure that we give a good balance at the end of the surgery. A level this way, that way, doesn't really matter to that extent.
Thank you. Thank you, sir. Amit bhai.
Thank you. As everyone said, I don't use Lenke except for documentation. I just use my general principles of selection of fusions for all my cases. And I do agree that one level here or there, for a practical matter, I think we should err. Of course, we are not in that institutes, but our regional requirement is quite different compared to the other regional requirements. And we may sometimes end one level more, which may be a better in the long term rather than in the short term. So that's what I usually do in my practice.
So Ranjith, your dancing comments.
I am totally agree with what Amit sir and Surya sir, they all said. I tend to be on the safer side. And whenever we have our own complications, our own adding on, when you go and see, really they tell us what we go wrong. And when I see my 15-year ago, see them today, and what has added on, it's something wrong I have done. I either understood the curve inappropriately, or I did not do a good correction. I did not do a lordosis correctly. And when you go and see literature, this has been mentioned. Lenke or King or whatever you call, PUMC, whatever you call. Somebody has seen it, they have put it down, only we did not realize it. And somebody has said a solution also. So as we really mature over time, try and see what all those small points, other than just putting screws and putting a rod inside, like you heard Professor Basu mention that with the type 1, type 2 ones, structural ones, that's a very important point. Unless you really hyper contour the rod and try to get the rod to the screw, they pull out. They pull out immediately or over time they pull out. So these things we learn over time. They probably are not told in the books. So we really see over time that what failures we have. This is same with me. So as we go on, we analyze our own result long term. We try and learn, and we can add on to it. Like Dr. Jhala mentioned, Lenke is just a framework. At least we can talk. Today we are talking because we have the 6 Lenke types. So that's a use of that.
Thank you so much. Ajay?
Same way, Lenke is the only classification I would use for communicating. I don't remember King. I don't remember any other classifications. You won't fail if you are following the CD rules. CD rules coming, quarter opposite rules are unpublished rules. He could never publish those. So you have to accept those rules. You don't fail with CD. The more longer the construct you are making, more you have to think because you are leaving less room for compensation. And anything which is decompensating in the immediate post-operative, likely they are going to get recompensated again. So there is room for many of the things if you have left out enough curves out. So don't think that anything goes wrong. So longer the construct, there are more problems also. Just remember this.
Thank you so much. And before we go finally, let me ask Tarak, who introduced the Lenke's classification, that what is his concluding remarks now?
Yeah, Niraj, I slightly differ from all of the faculties. I think I don't mix two philosophies. So basically, the Lenke school of thought is mainly dissecting out deeper and deeper, and they basically want to make everything objective, everything which is relied on numbers. While the other philosophies are basically more of a principle-based philosophies, which majority of the faculty is talking about. So I still remember in one of my scoliosis week with Dr. Menon, who never believes in any kind of classification, and he totally, decide his plans based on the principles which we have discussed in last 2 hours. But I think Lenke's group and the other people want to make everything more and more objective, and everything, all decisions they want to take on based on the numbers. And I think that's why there is a conflict. So I usually don't mix these two kind of philosophies.
Niraj?
Yes, Ranjith, one quick comment.
Yeah, no, it's a question to Dr. Amit Jhala and Dr. Professor Basu. Now, the people with the longest follow-ups in this. Sir, how often have you seen distal adding on in your cases where you're stopped at 4? Like how often you have to operate on a 4-5 disc in a case where you stopped at 4, or a 5S1 disc where you stopped at 5?
Basu, sir?
Yeah, Amit.
I have never seen. I was just going through all my cases right from 98. Then when I started, from 98 till now, I have never seen any L4-5 or L5S1 problem. I had one patient who had a tumor at L4, which I had to operate, and then it was difficult. But I have an add-on phenomena when I have left my fusion at D12 or L1 or L2. So that's what I have. But I've never failed when L4.
Adding on is coronal plane. I'm asking about a disc degeneration at 5.
Never. Never. I've never done that.
Basu sir?
Never.
So this is the topic of the thesis of my current fellow. They're looking at more than 10-year follow-ups of all scoliosis patients of AIS and trying to find out what is the disc degeneration which is happening. Again, that brings us to the point of clinical versus radiological disc degeneration. I hardly see a patient with back pain. I have more than 15 years follow-up of patients. They don't come back with back pain, but they have disc degeneration at the distal level, even if we stop at L3 or L4. Regarding coronal decompensation, yeah, Amit.
Yeah, the only problem, as I said in my lecture also, that they want mobility. And it's not for degeneration, but it's for the mobility of the lumbar spine that we should save the levels.
I'm not sure whether we stand a big chance of gaining mobility if we stop at L3 rather than going down to L4. That's something which needs to be really proved by very good studies. So that's actually has not been proved, but it's been. I'll try to see whether this thesis comes out with something of value regarding this degeneration in long-term follow-up versus back pain for these patients who've been fused for AIS.
I have one patient who had a L4-5 massive disc with secondary canal stenosis after 17 years after instrumenting and stopping at till L4.
17.
So then I had to, that was stainless steel implants at that point in time. So I had to do a CT because it is very close to find out. So for that case, I had to extend the fusion to L5 after a long time. That's the only one case I have.
Okay, so I guess, we come to the end of the session. Unfortunately, our president, Dr. G.D. Taradra, has to leave for his family health issues. May I invite our Vice President, Dr. Subir Javeri, to do the honors for valedictory as well?
Well, hardly anything much to say after an excellent session. So I thank you all, Basu, Amit Bhai, Surya, Ajay, and Ranjith, as well as Tarak, for an excellent presentation today. And we look forward to the second part of this seminar that Niraj has planned in a month from now. So thank you all for an excellent presentation and an excellent interaction. Thank you very much.
Thank you. Enjoyed. Good night.
And before we go, I guess, just would want to thank Niraj Bijlani and OrthoTV, and as well as our sponsors, INTA Sequela Division, for sponsoring this event. Thank you so much. Thank you, Niraj.
Thank you.
Thank you all. Good night.
Bye.
Thank you. Good night.
Bye.
Thank you.